Hello there, listeners. It's Susie New from the Australian Society of Anaesthetists, and thank you for listening. This is episode 105 of the Australian Anaesthesia podcast. I am so excited to bring you this episode because I know that we can all relate to this. Did you have those days as a registrar when you've just finished inducing a really sick patient, it's the middle of the night, and a resident on the ward calls you because they can't get an IV in? Or I remember back in the day when you'd go and help out with an IV on the ward and the resident or registrar would hang around, or even better, would have the IV trolley all set up ready for you and you'd be there able to give a few tips while inserting the IV. Or the other day, I worked with a nurse who was brilliant at putting in IVs, knew exactly what size and the site I preferred, and this nurse, they were keen to teach other nurses, but there was no avenue to do that. And finally, what I'm seeing more commonly now is patients who are needle phobic or very needle hesitant, and that has arisen from previous trauma from IV cannulation. Well, my next guest, Dr Pip Lane, has pretty much solved all of these problems, or at least is making a huge impact on managing difficult IV cannulations and reducing unnecessary cannulations and the trauma associated with them. She brings up one of my pet peeves, which is telling patients, sharp scratch now, as we are putting in a cannula. So if you stop listening now, please at least come away with the goal, with the promise to your patients that you will reduce nociceptive language. I'm a really big believer in our words matter. Anyway, in this episode, we are diving into this service. It's called the FAAIRI service. It is no surprise to me that it has won so many awards. Of course, I picked Dr. Lane's brains on how she got this service all up and going. I'm hoping it gives you some ideas because I'd love to hear that more hospitals, more health services are taking up this challenge of managing IV cannulation well. All right, let's get into it. Great seeing you again. It's been a long time and I love seeing how your career is going. So thank you so much for giving up some time. This morning we are talking about FAAIRI. I love the acronym. It's FAAIRI. I didn't say that last I properly. FAAIRI. Now, what does it stand for?
It stands for Fast Access and Advice for Intravenous Routes with Imaging. So we kind of fitted the acronym into the words to make it fit and make it child-friendly.
It's perfect. I love it. So tell me, in a non-acronym way, what does it mean? What does this service do?
So it's a paediatric vascular access service. Well, actually, it's a vascular access service that services the whole Women's and Children's Hospital here in Adelaide. So we do look after the obstetric women as well, but the primary focus is, and most of the work is the paediatric. It has multiple roles and the workload has exponentially grown since it was formed in 2021, which we knew it would.
It fills a huge gap, doesn't it? I think everyone's had the idea that we need something like this, but amazing, and kudos to you and the team for actually getting it up and going. So can you walk me through how it works?
Yeah, sure. So we have two FAAIRI nurses, our vascular access nurses. It's actually currently only funded for one paediatric vascular access nurse, but there is a second nurse that the South Australian Medical Imaging have helped support as well while we're waiting for additional funding. But they receive calls from people throughout the hospital asking for assistance with people who have difficult IV access, and they perform ultrasound guided IV access on the wards. They go to the patient to do that on the ward or in medical day unit or paediatric emergency or theatre or wherever the patient actually is, rather than having to bring the patient to them. So that's one of the roles that they do. They also give advice about the right lines that kids should have depending on what their treatment should be, which is really important because one of the aims is to make sure that people get the right line the first time that will last for the duration of their treatment. So it really minimises the number of insertions that they need to have. And also the idea that it minimises the amount of complications. So you're not getting kids who actually should have a PICC line for their therapy, for example, highly irritant antibiotics to veins that can cause lots of problems, that they, instead of having a peripheral line, that they actually have a central line put in early that can last the duration of their treatment. So they give advice about that. They insert PICCs as well.
Wow.
In interventional, in the angio suite under the supervision of the interventional radiologist. The radiologists just do a line check really, but otherwise the FAAIRI nurses do the whole insertion, including consents. There's a lot of education that they do. They educate families and patients on their lines. They do education for the trainee medical officers when they start their rotations at the Women's and Children's Hospital about tips and tricks on how to do IV access in children, because we know that that's a very different way of doing than in adults. For example, procedural holding, distraction techniques, the way in which we talk to kids as well to help them get through procedures. They also do education of nurses on the wards, and they've just had funding this year to be able to do education for the medical day unit nurses, for example, because there was a lot of work that was outstripping the ability of what we're funded for, which is 1 FTE, to be able to put in lines in medical day unit for those patients coming in for their infusions, for example, for the day. And so they're training up those nurses who can do ultrasound guided IVs as well. There's education programs going in paediatric ED, and they've recently just started a service where they'll go out to families at home to be able to support the hospital in the home program. So for patients who, for whatever reason, can't have or are not ready to have implantable devices like a port, for example, for thalassemia or sickle cell disease and are transfusion dependent, they will go out, take the ultrasound out to the family's home for difficult patients, put the IVs in, and then they will have their blood transfusions at home, because Women's and Children's Hospital have also started a home transfusion service in the last year or two, which is amazing patient-centred care. And so it supports those, So the hospital and the home nurses are actually trained up to do IV insertions, and they have been trained by the FAAIRI nurses. But for those difficult patients, the FAAIRI nurses will go out themselves and do those difficult patients. So there's a huge scope in what they do.
Huge. I want to go back and just pick through those things that you mentioned. So you started with saying that it's for children who have difficult IV access. Are there criteria that they have to meet in order to be accepted to be seen by a FAAIRI nurse?
Generally, we have some guidance, but FAAIRI nurses are happy to take a call anytime someone's concerned. So it might be because of the child's age, it might be because their clinical situation, because they're dehydrated, and so there's no visible veins for the first-term paediatric RMO who hasn't done many IVs to actually do the insertion themselves. It could be because the medical staff have had a couple of goes already. We do have a guidance that no more than 2 attempts, because we want to preserve veins and we want to also decrease trauma in children and their families as well. Anyone who's got a known history of difficult IV access as well gets an automatic call to the FAAIRI service, and then they can go and assess. And also, just because you've had history of previous difficult IV access doesn't mean you will then go on to have that for the rest of your life, because it can be situation dependent.
Correct. I like that it is situation dependent. It's not just based on the number of attempts, because often we get referrals from the ward to say, we've had 5-6 goes, now it's time to call anaesthetic. So I like that you can call anyway, whether you've not even attempted, because as you say, the child might be dehydrated and there's nothing to see. So rather than having 1 or 2 attempts before you call anaesthesia, you can just call FAAIRI straight off the bat. So I think that's really good. It changes the impetus.
Yeah. One of the things that people were concerned about when we were about to roll this out was de-skilling of medical staff in doing IV access. But what the FAAIRI nurses will do is, if they get a call from the RMO, they will go and look at the patient with the RMO or the registrar, whoever, and talk to them, decide whether the RMO wants to do it with the support of the FAAIRI nurse, so that they can have a skilled person observing them, rather than having the see one, do one, teach one method of learning that has been in medicine for a really long time, which we know is not successful. Or the RMO can be there to watch the FAAIRI nurse to get tips and tricks for next time as well. So the idea is that we'll support, and the auditing that we've done of the FAAIRI service shows that the RMOs feel more supported and more skilled in IV access in kids by the time they finish their rotations, which is really important.
That's great. That's an important thing for them to learn. I want to move on to, you talked about they would provide advice on the different line types. So what types of lines do you have? And for people who don't know, can you just give us a bit of a framework?
Yeah, so I think there's 4 broad categories of lines. There's peripheral intravenous cannulas.
Our usual drips, yep.
Then there's midlines as well that we use. So midlines are long cannulas that you put in above the cubital fossa, but the tip needs to be below the start of the axillary vein. And so they can actually be indwelling for up to 28 days. So they're actually a type of peripheral IV, but they're a long dwelling one. We use a sterile technique, so that increases their longevity as well. So you still can't put things that are highly irritant in vessels through those. So things like you couldn't put chemotherapy or TPN or things like flucloxacillin or vancomycin are really irritating to veins. So if you're having long-term therapy with those, you're better off having a central line. Central lines can be categorized in lots of different ways. There can be PICCs, which are peripheral intravenous central catheters. They go in above the cubital fossa with a tip near the right atrium, near the big vessels, just before they enter the heart. And the FAAIRI nurses will put in a lot of those. Things like CVC, central venous catheters rather, that anaesthetists are used to putting in theatre or intensive care doctors, they don't do those. And including tunnelled lines, we still do those either with the interventional radiologists or just a basic CVC, and anaesthetists or intensive care physicians will do those. And then you've got your implantable devices as well, so your more long-term lines. So they're things like Hickmans and infuser ports as well. In our practice, the surgeons or the interventional radiologists do those.
And can you give some examples of what medications you would consider putting in a midline?
So any antibiotics or fluid therapy that is not highly irritant to veins. So if you had appendicitis and you needed to have a few days of IV antibiotics like cefazolin or something, that would be fine to go through a midline. If you needed IV fluids for a few days or a couple of weeks, but you're able to actually have enteral nutrition, that would be fine. But for things like TPN, that needs to go through a central line. It just means that they're more secure and they just last longer. You can't take blood out of midlines though. We don't encourage that because that can increase the risk of occlusion. If you're wanting to do things like taking regular blood draws through lines, then it really needs to be some sort of central catheter.
Great. Some really useful tips there. Thanks, Pip. You mentioned they do some education about talking to kids, holding kids. Can you give, again, so people who might be listening who are the occasional paediatric IV cannula inserter, some tips for how we might communicate with children and how we might hold them?
Sure. There's lots of different ways to communicate with kids, and the words that we use are really, really important. And one of my colleagues, Rob Lang, has done a lot of work with Alan Sina, who's a guru of how we talk to people, communication, and both of those former colleagues of mine at Women's and Children's are fantastic. So we've got a really great culture of how we speak to kids in our unit. And Rob has created, with some other anaesthetists, the Effective Periprocedural Communication course, the EPIC course, which is run through SPANSA, the Society for Paediatric Anesthesia in New Zealand and Australia, which I feel very lucky to be currently the president-elect on. So I get to be
congratulations.
part of that. Yeah, really amazing work that they do there. So Rob and some others created EPIC. And so the module that we created for the FAAIRI service has been based on his work and that preliminary work when he was developing the EPIC course, which was really great. So I think things like not using negative words, not using suggestive words. Well, negative suggestions would be a better way of saying it. So things like, it's just a little scratch, it's just a stick now. All these things that people have been saying for decades, really being very well-meaning, but actually you don't know how people are going to actually respond to having a drip put in. You're making a lot of assumptions about how they're going to interpret that sensation. And there's lots of things that we can do to make it comfortable. Putting on things like Angel Cream or LMX, using distraction techniques, iPads, screens are amazing in these sorts of things. Allowing kids to watch if they want to watch. Some kids really like to know exactly what's happening to them. They don't necessarily need to be, oh, don't look, don't look. Not using words like needle, for example. I use a magic straw often when I say we're going to put a magic straw in or we're going to put some plastic tubing. If they say, is there going to be a needle? I just say yes, but then it will come out. You don't lie to kids. You just tell them as it is. It will come out and it will just be a soft plastic straw. And then some really encouraging things like, how did that feel? Was it better or was it the same as what you thought it would be at the end of the procedure, is what I say. Because often what they might imagine is a lot worse than what actually happened.
Correct.
And if it's the same, you're no worse off. The stuff that we can do in the way which we talk to kids and also adults, which I know that you've talked about on your podcast before, they're transferable skills and they make a huge difference into how people actually respond to procedural care.
Oh, Absolutely. Big plug for Epic. I haven't done it yet, but I've certainly been to some workshops and sessions that Alan Cena has run, and I certainly learnt a lot from him and have taken that into my pediatric practice. But there's always room to grow and improve, and I love some of the tips you've shared there. I'm going to take some of those away into my practice as well. I wanted to move on to ultrasound and the technique that you use. I know there's some people who are big fans of in-plane, out-of-plane. Are you prescriptive with how the nurses do it? How have you encouraged them to use ultrasound?
They can do it either way. It will depend on the situation, whether they'll use in-plane or out-of-plane. I don't think it really matters. What I think is you just need to be able to see the tip of your needle and be taught both ways, because not one way is the right way for every way.
That's a really diplomatic but also pragmatic answer, because some people get very passionate about one technique or the other, and I sit with you. You've got to try and master both if you can.
Yeah, I think as a paediatric anaesthetist, you have to be pretty pragmatic, because it doesn't matter how good your plans are, you just got to change them on the fly.
That's right. Kids are designed to throw us curveballs, aren't they?
Yeah.
I want to move on to the leadership, the change management, because getting a whole new service, as I said at the start, many of us have dreamt about this existing in some of our workplaces, but to actually get it up and going. So thinking back, you said it first launched in 2021. If you could go back to then, thinking, what was the lead time like? How did you get support for this idea? Let's start with that.
Yeah. So I've learned a lot about perseverance doing this project. If I go right back, what happened is I had my second child in 2018, and before I went on maternity leave, we had what we called a PIC nurse in the hospital, and her name was Shelley, and she was actually working within the radiology department of Women's and Children's. The way it works in South Australia, just to give a bit of background, there's different health networks. I work for Women's and Children's Health Network, but all the radiology services are provided by South Australian Medical Imaging, which is a completely different health network. So they have departments within each hospital. So Shelley worked for South Australian Medical Imaging, we call it SAMI for short. She had some funding and training years before to learn how to do PICS, and was really well supported by the interventional radiologists, the paediatric interventional radiologists at the SAMI at Women's and Children's. But unfortunately that funding was not actually renewed after a few years. And so despite the fact that her being able to do PICS really lessened the burden on the interventional radiologist, and we don't have an interventional radiologist 7, even 5 days a week at Women's and Children's during working hours. So it was very helpful. And so we had this frustration that we had this person who was highly skilled and was able to help children, was not actually able to do the work that she was trained for. So I said to her before I went on maternity leave, when I come back, I'm going to set up a vascular access service. And she laughed and said, all right, yeah, sure.
Great goal. That's what we always say. Set your goals. Know what your goal is. Be clear about it.
Yeah, that's right. I don't know whether it's a smart goal, because sometimes it didn't seem achievable.
Sometimes you just got to dream big.
Exactly. So I came back to work about a year later, and I started doing some benchmarking as the first thing to find out what everyone else in Australia was doing. And so that just involved phone calls to all the different tertiary and quaternary paediatric centres in Australia. And then I organised a stakeholders meeting, which was with all the people who I thought would be important to get on board, which was a very interesting meeting because there was some resistance at the executive level for the need for this, even though the clinicians on the ground were very adamant that this would be a fantastic thing. So there was that disconnect, and I very quickly learned about you have to get hearts and minds on board and you have to get all the right people in the room. So that was about August 2019 that I had that first stakeholders meeting. And then what I did is I just tried to find out all the people who were important within the organisation that I needed to get on board, because we got to get those right people on board to be able to sell your message. And the other thing that I did, which was really helpful, was at the SPANZA annual scientific meeting in 2019, which was in Brisbane, I did a persuasion workshop. by an anaesthetist who is from Tassie.
I know the one. And can I give a big plug? He's running that workshop at the ASA NSC in October.
Oh, you should definitely go if you can.
Yeah, no, I've signed up. I was trying to get him to do a workshop for ASA Council, just one of our development workshops. And then I thought, now that I know he's at the ASA NSC, I will suss it out.
He was fantastic. So that was very inspiring to me. And the thing that I took away from that workshop is you've got to send the right messenger to deliver your message.
Nice.
Because you might not be the right messenger. And so I went away and I thought about who were the right messengers to deliver my message to the hospital executive, because I needed to get them on board and I didn't really have them on board. And so then I went and spoke to the executive medical director. And she was supportive but skeptical, to be fair, because she thought, oh, people have had this idea before, it's never worked. And I said, well, I've got all these people on board. And she was very good at going and getting the rest of the hospital executive on board to in principle agreement.
Great.
So that was helpful. They wouldn't have listened to me, but they listened to her. So essentially, she delivered my message. So that was an invaluable workshop in terms of getting the FAAIRI service on board.
Amazing how that just landed at the right time for you. You might have done that workshop 5 years before and the message might not have landed that way.
Yeah.
Fantastic. That step is change management 101, isn't it? Know your environment, and different people phrase it different way. Get your stakeholder group, get your learning community, whoever it is, get all those right people in the room. Where did you learn this, or did you just figure it out intuitively?
I kind of learnt as I went, and I just talked to a lot of people.
Amazing.
One of the great things about doing this service, slight digression, is the amazing people that I've met across the network that have been outside my theatre bubble. Because as an anaesthetist, it's really easy to stay within that bubble and know, you have amazing nurses who work in the perioperative space and the surgeons and the intensivists and things. But it's all of those other people who are doing amazing work within the hospital system. So, for example, some nurses had started a vascular access working group that was headed by the infection prevention and control advanced nurse. But it didn't have a lot of buy-in from medical staff. It had a lot of buy-in from the nurses who are on the ground looking after vascular access devices all the time. And so I got myself onto that working group, and the infection prevention and control head, Georgie Kukulis, was amazing. And she was one of the instrumental people, because she said, we will do the auditing, we will look after the maintenance of these devices. That's how we can help. This is how my area can help.
Wow.
And so the other people that were really helpful was the South Australian Medical Imaging Nursing Director, whose name's Susan, and she has a real passion for improving vascular access care in South Australia in both peds and adults. And she was like, we need to get this up and going. This is how I can help. I'm going to make sure that we can get some funding. So without her creating that opportunity for funding and creating a business case to get that money, it would never have come off the ground, because what this actual service is a collaboration between Women's and Children's Health Network and South Australian Medical Imaging. So it's been an amazing collaboration. So
yeah, it's amazing. There's so much leadership stuff I can try and unpack. So let's maybe quickly go through a little bit of it. The one thing I loved when you're describing getting the stakeholder group together right at the start was getting everyone's hearts and minds on board. And it just was really topical to me, because I'm meant to be in Boston this week, and part of that is also doing a leadership subject. And there's this discussion about the Harvard negotiation model of separating the people from the problem. And there's another school of thought, so the Chris Voss hostage negotiator school of thought, which is you can't divorce people from the problem, because we're in it with our hearts as much as our minds. If you're negotiating with a hostage taker, you can't take them out of the situation. They are the situation. So, have you got any thoughts on that?
Yeah, I mean, personally, I think that we are healthcare professionals. Healthcare is a vocation, as how I see it, and people care about their work, and people come into it with all sorts of different preconceptions and experiences and things. And I just think that you have to respect that people have a lot of feelings about stuff, and you can't separate the intellectual from the feeling, especially in health. I mean, that's why we get moral injury, because we can't just separate, we can't just turn off our hearts when things happen. So I think, I know it's such a cliche, but I think you have to really bring people along with the journey and harness their strengths and things, And sometimes you just have to have a thick skin when people tell you no and complain about stuff or whatever, but then you just have to sweep them along and say, come on, we'll just encourage you. And then people have all these amazing talents and untapped talents often. And if you give them an opportunity and a space to be able to do that, then they can just thrive. And it's been really amazing seeing some of the people within this space, just their careers going in quite a different direction because they've got these new opportunities. So, yeah, it's amazing. And on a day-to-day basis, I'm actually not involved in the FAAIRI service running at all now, because my plan was always to set it up so that it actually didn't live and die with me, because that's not sustainable. And I think that's the other thing. I wanted to help create something that I could then step away with and just watch people then take it in the direction that they think is appropriate, and it can grow. It's got some good governance, not micromanagers, is I think important as well. But that's probably more my style.
That's an amazing insight. So that's very much what Heifetz describes in his adaptive leadership model. So it's about that initial getting people together, riding that distress that people might feel about incoming change, but ultimately about giving work back to the people that you work with, because they're the ones who are going to carry it forward, and you're going to let them express their ideas, take their talents somewhere, and not, as you say, micromanaging it. So you might not know the theory, but you certainly have practiced it amazingly. You're an amazing leader, and it's just come naturally to you by the sounds of it.
Well, it's trial and error, I think.
Exactly. It's often after the fact that you go, oh, some expert has written about what I've just done. Fantastic. The other concept I wanted to run past you is this concept of it's called a learning health system. So it sounds very much like what you have done, which is getting your stakeholder group, they call it a learning community, to help define the problem, and then going around in a cycle. So I just wanted to see, it sounds like that's what's been happening. So first they collect data, turn that data into knowledge. What are we doing? What's our IV access rate? Like those sorts of things, turning that knowledge into performance. So how do we implement it? And then how do we keep monitoring it? How do we keep measuring how our service is doing? So what have you measured over time, and what changes have you seen in the service since it was implemented in 2021?
Yep. So I think you're talking about the quality improvement model.
Yeah. Plan, Do, Study, Act.
That's the one.
That's part of it, yes.
So we were really fortunate when we were setting up the FAAIRI service, in that the Women's and Children's Hospital had employed a principal continuous quality improvement consultant who had a lot of expertise in this area.
Aha, perfect.
And so he was really helpful in using all of that quality improvement methodology to be able to set it up in a really concise way, I guess, which I don't have any expertise in that. I'm the person who comes in, hey, let's do this. But the actual theory, as we've talked about, I don't know the theory of quality improvement and leadership. Yeah. But and it's great because he taught us a lot about that stuff. So that's been really good. So we looked at what we were doing and collected a whole lot of data about who was doing difficult IV insertions, which is pretty much the anaesthetic department. And so I basically started a logbook of every time we would get called to know what the scale of the problem was, because prior to this, what would happen is a difficult IV access, they would either call anaesthetics or they would call PICU. And depending who was available, someone would come. And sometimes no one was available because everyone would be in theatre, or PICU were really busy.
Exactly. We've got other roles.
Yeah, exactly. And kids were getting massive delays in IV therapy, which was potentially life-saving. We had one case that I remember very vividly, was a 3-year-old who came in. Initially, it wasn't a clear diagnosis of sepsis, but then was admitted and then became quite obvious. And so they wanted to start some IV antibiotics, but she was very dehydrated. No one could get a drip in. She waited all night to have a drip put in. A consultant in Ether just put one in first thing in the morning when they arrived at work. But it was about, 13 hours after the decision of wanting to give antibiotics by the time she actually had it. Now, she could have died.
Oh, yeah.
Luckily, she didn't. But by the time she actually had a drip put in and some bloods taken, she was coagulopathic.
Oh.
And she's fine. She responded really well to treatment, and she was discharged a couple of days later, which was great. But these are all things that are really dangerous, and it's not good enough. And there were some of the big drivers of what we would see, let alone as an anaesthetist, you get called and someone has a 2-year-old's had 8 attempts for an IV, and they're screaming and the parents are in tears. And we're creating situations where we have medically induced trauma for these children and the parents, and then no one wants to come and see us.
And we should do better.
Yeah, that's right. And then the other thing, just as a side, that I get really worried about is, If we do this to children and their families, they won't come to us when they need help.
Correct.
Because they'll be too afraid to actually engage with the health system, and we're setting them up for a lifetime of healthcare avoidance. So when they're 40 and they get chest pain, they're too frightened to come into the hospital to seek help. I know that's quite extreme, but we're creating that groundwork. Whereas if we create groundwork that's positive for kids who need lots of drips and stuff, they'll come in and they're not frightened anymore. And we've got the evidence we've collected with the auditing that we've done with the FAAIRI service. We've got testimonials from patients and their families in that since the FAAIRI service has started, they're not afraid to come into the hospital anymore to have their drips put in. For these children who come in regularly to medical day unit to have their infusions.
That's amazing.
And so their interactions with our healthcare system have vastly improved. So just in terms of actual numbers, since the FAAIRI service started, the number of PICs from what they were doing per year, just the Women's and Children's Hospital in SAMI at that site, it doubled in the first year of the number of PICs that were being put in, because what was happening is people were identifying that they needed to actually have a PIC for their therapy. And that's been consistently that same level since the FAAIRI service. In terms of peripheral IV cannula insertions, and remember, this is only a service at the moment that's is 8:30 to 4:30, 5 days a week currently. And so they were doing up to 600 PIVC, difficult IV access insertions a year.
Wow. And
now that they have actually increased their education to some other areas of the hospital, the number that they're doing has slightly decreased, but only by about 80 or so at this particular time in the last audit. And that is because they're being able to upskill and other people can do it. But what's happening is because we're only one FTE at the moment, the demand is outweighing the supply.
And it sounds like after hours is a bit of a gap that you might be looking to fill as well.
Yeah, well, there's currently a business case that's being worked on to increase the hours of the FAAIRI service to 8 o'clock at night and for 7 days a week. We've got some good support from the SAMI executive to do that, but it's just in that final stages of being worked on. So fingers crossed that will be rolled out soon.
That's amazing. And the evolution continues. That totally fits with that learning health cycle I mentioned before.
Yeah.
Look, it's an amazing service. I should also mention you have won a number of awards, the Women and Children's Health Network Excellence Awards, South Australia's Nursing and Midwifery Excellence Awards. There's the Fast Feed and Wrap project.
Yeah, the Fast Feed and Wrap project actually is a different quality improvement that was done with Laura Burgoyne and Fiona Taverner a few years ago, and with the South Australian Medical Imaging team as well. And the idea of that was that neonates don't actually need a general anaesthetic to have a central line put in. So what they do, they look for their veins while they're awake, put the LMX on in the appropriate spot.
LMX, for those people who don't know, we use EMLA or another term, so topical local anaesthetic.
Yes, that's right. Yeah, and so they fast them, they give them a feed, a bottle or a breastfeed. The baby goes to sleep, they wrap them, and then they're able to put a PIC in without a general anaesthetic. So it really decreased the number of general anaesthetics we're having to do for that vulnerable population, which was really fantastic.
That is amazing. And they must be pretty slick. I convinced the radiologists that we can feed and wrap the bubs for a CT scan, because the CT scan's like a few seconds. But to do that for a PIC, it must be both the feed and wrap is working, but also the people who are putting in the PIC must be pretty slick.
Yeah, they are. They're very good. But that just takes practice. And like anything, that's a learning curve. And the other one that was really nice award that was lovely recognition for the FAAIRI service was that last year they won the Australian Council on Healthcare Standards Quality Improvement Award for clinical excellence and patient safety.
That's amazing. Australia-wide recognition. Yeah, well deserved.
Yeah.
Well, look, just as we wrap up, is there anything else that you want to say about the service, about how we can improve things for kids?
I think the thing that I have liked about this is that as anaesthetists, we get to look after one patient at a time and create excellence for that patient. But being involved in this sort of project has been super rewarding, because it's a way of creating change on a bigger scale than that one patient at a time, which I think has been really nice. And that's been as a consultant, there's opportunities to do that with that clinical support time that people should get. But without that clinical support time, there's no way that I would have been able to do this project. So it's fundamental for all of those quality improvement, quality assurance activities that are really important for us to do. But also, I've just learned heaps in a selfish way. I've learned so much about the people I work with. I've learned about myself, and it's been very rewarding from that point of view too. But yeah, I'm just in awe of my colleagues as well, because people really care. And we work with a bunch of people all the time who really care about stuff, and it's nice to see them thriving.
Well, I'm a bit in awe of you. I think you've just done an amazing job getting this up and going. You're demonstrating some amazing leadership. Yeah. That was a good plug there for clinical support time. So big thank you to the AMAs and the ASMOFs around the country for having clinical support time built into our EBAs. And thank you so much for joining me this morning, and wishing you all the best with your next endeavour, and FAAIRI, of course.
Thank you so much, Susie. It's a real privilege to be able to speak with you today. I really appreciate it.
Well, I hope you enjoyed hearing from Pip. What a remarkable leader, and really what a fantastic service. Of course, it takes time, energy and effort to develop something like this. And as Pip mentions, this is a great example of why we need clinical support time, otherwise known as non-clinical time. Big thanks to the AMA branches around the country who advocate on our behalf to have this as part of our award. I'm declaring a conflict of interest here, as I am currently an AMA federal counsellor. Nevertheless, I do encourage you to join the AMA as a recipient of these benefits, and to support the ongoing work to ensure that we have fair, reasonable conditions in our public hospital workplaces. Here's 3 podcast episodes that you might be interested in listening to after this one. Pip mentions that I have discussed communicating with children in this podcast. That was in episode 55, where I chat with Dr. Annette Webb, a paediatric gastroenterologist who was also president of the Australian Society of Hypnosis. We talk about the language we can use around children so that we can have smoother inductions and minimise trauma. Some of these tips would also be useful when we're looking after adults too, because who isn't slightly nervous when they're coming for surgery? Pip also mentioned that she did a persuasion workshop, and that helped jumpstart getting this service up and going. You too can do this workshop. It's part of the ASA's National Scientific Congress, which is being held this year in Canberra from the 2nd to the 5th of October. Just look up Persuasion Masterclass when you register. To find out more, visit the asansc.com.au website, or listen to podcast episode number 104, where I chat with the convener, Dr. Girish Palnitkar. And finally, if you are a woman and you want to tap into the secret sauce of leadership, or you're a man who's got some of that secret sauce to share, then why not join me over at WELI, which is the Women's Empowerment and Leadership Initiative. I talk about WELI with 2 of the founders, Professors Nina Deutsch and Larry Schwartz, in episode 83 of this podcast. I'll put a link to our Australian chapter of WELI in the show notes, as well as a link to the ASA NSC. I hope to see you in Canberra, and I hope to see you in the workshop. I've already registered. Until then, I hope you stay safe and well out there, and I thank you for listening.
This has been Australian Anaesthesia, produced by the Australian Society of Anaesthetists, with many thanks to host and editor Dr. Susie New, with music by Soda Lime Music, sound and engineering by Bearview, and graphics by the ASA Communications team. For more content, please visit www.asa.org.au.